Good morning. For those of you who don't know me, I'm Keith Welchie. I'm Director of Healthcare Informatics at the BJC Center for Clinical Excellence and one of the WashU infectious disease faculty here. I also try to avoid using antibiotics, and narrow spectrum is good. I concur completely. And those of you who know me know that part of my role at BJC Healthcare is focusing on our safety and quality initiatives, how we measure that and promote quality. So in that guise, it gives me tremendous pleasure to introduce Bimal Desai as our next speaker. Bimal went to Emory University in his home state of Georgia for his undergraduate degree before coming here to St. Louis to get his MD at Washington University School of Medicine. He then headed northeast to Philadelphia, where he was an intern and resident in pediatrics at CHOP, followed by a chief resident year. He then continued to stay on, where he's now an assistant professor of clinical pediatrics at the University of Pennsylvania. Bimal is now the chief medical information officer, as well as the medical director of healthcare information management at CHOP. Bimal has focused a lot of his professional career on how to use clinical decision support and the EHR to promote safety and quality. Has published and spoken on that extensively. He's also one of the developers of AMIA's board review course for the clinical informatics boards, and so that's how I became most familiar with Bimal, is when I used that course to help me pass the board. So thank you, Bimal, for that. Bimal will be speaking to us on how to develop an EHR to support clinical and quality objectives, and I really was looking forward to it. And I thought my esteem for Bimal could not go higher until I noticed this morning that he's got a Baymax sticker on his laptop, and if you haven't seen Big Hero 6, you need to. So Bimal, welcome.
Thanks so much to Keith for that very generous introduction, and to Pele and the rest of St. Louis Children's for hosting us today. Let's see. So I wanted to talk sort of at a more practical, applied level for the group of you in the audience who are implementers or that are involved in the design and configuration of your electronic health record. I do have two disclosures. As Keith mentioned, I'm a compensated lecturer for AMIA, and I'm also involved with a healthcare startup called Haystack, but I'm not going to discuss either one of these things today. So I want to go back to 1996 when I was a med student here and talk a little bit about my experience as a student in the School of Medicine. I was in a band with a cardiologist here at Barnes named Greg Schilling, and Joel Schilling, and we were quite successful in our own time. We sold out at Cicero's and at Blueberry Hill, and we knew that we needed a menacing name because all heavy metal bands had like really, really tough sounding names. And we were taking our Med Micro course as second-year students at the time, and literally the scariest thing we could think of was this prion disease called Kuru, which you get from eating human brains. And if that's not metal enough, I don't know what is. So there, this was my fondness for Blueberry Hill grows each time I go there, and. We also did a class skit, which I'm trying to remember why we did this, but the theme was Christmas in July. So it involved me dressing up in a strange 70s disco outfit. And there used to be, I don't know how many of you remember this, but at the corner of Lindell and Euclid, before there was this beautiful public library, there was a kind of a rundown old building. I used to live there. It was, the rent was extraordinarily cheap, split 4 ways, but, maybe it was a sign that we shouldn't have lived there. It was the very next year that we moved out, they tore the building down. So, I also benefited greatly from all the mentorship and the faculty here in the School of Medicine and also at St. Louis Children's. I took a pediatric rheumatology and immunology rotation with Jonathan Gitlin as our attending, and Andrew White was, I think, a first-year fellow at the time, and impressed upon me a lot of useful tricks of the trade. Penny Shackelford was my Pete's clerkship attending, and I have very fond memories of that. She probably correctly did not give me an honors in that class, and it still stings 20 years later. And then the late Jim Keating was my sub-I attending, and we had some really nice conversations about pediatrics and my career goals and things like that, so I owe a lot to the school. So I'm going to cover 3 topics. One is to talk about the link between quality and safety and informatics. And we don't have the 100% solution at CHOP, but I want to give some insight into, based on some of the projects that we've worked on. I also want to talk about strategies to support pediatric medication safety, and specifically the guidance that you provide to your care providers as they're ordering medications. And then finally, talk about the 5 rights of CDS and user-centric design, specifically with regards to alerts, because everyone hates alerts, and I think that there are things that we can do proximally to sort of improve them. And just to give you a background about CHOP, and I think Brian might actually talk about some of this, but these are statistics about the Children's Hospital. I'm not going to go through them. The one thing I do want to highlight, though, is we have this ACGME accredited fellowship in clinical informatics, and the 2 fellows per year that we graduate do rotate through their sort of applied clinical informatics curriculum, so they take a leadership class with me, and they go attend our CDS meetings and things like that. And we look forward to hearing great things from these fellows in the future. About IS and my team, so my team reports up through information systems, and we've been fortunate enough to be recognized by Computer World and Healthcare, some survey that looked at which are the most wired hospitals. My program specifically, I fund 24 physicians, anywhere from 10% of their time up to about 50 or 60% of their time, specifically to work on health IT, realizing that they have to have time to do this if we want to do it thoughtfully. And parallel to my structure, the director of nursing informatics also has a group of nursing informatics champions. The trade-off is that I expect all these folks to go out and get advanced training in informatics or to learn something about Epic design and build and to really become experts in that discipline. Between the Department of Biomedical Health Informatics and the Clinical Informatics program, we actually have, I think, around 16 board-certified informaticists. And I delegate the work through my 3 medical directors, who are fantastic. And in sum, none of this work could have been done without this entire structure supporting it. My role at CHOP is sort of spread out into 2 broad categories of health information management and electronic health record governance. On the HIM side, it's sort of like how you're supposed to use the record. So how do we want 10,000 people to simultaneously use the problem list correctly? And on the EHR governance side, it's how do we want to design this to meet clinical needs? And so the 2 are complementary and in many ways vital. I'll call out that one of the subcommittees of HIM, so it does have direct reporting up to the executive committee of the medical staff, is this clinical decision support committee. And where I think this model is going to evolve is that, we've historically treated this like an IT endeavor, right? Someone has something they need in the electronic health record, they put in a ticket, somebody fiddles with the ticket, maybe fixes something or updates something in the electronic health record. And what's changing is I think we need to call out the role of clinical informaticists as collaborators and consultants. And I don't mean consultants in the way of like, I ask you a question and you give me your opinion and you have no stake in the game afterwards. What I mean is, in the same way that I would call a consult to a medical specialist to help me diagnose, treat, and manage a patient, we should think of clinical informatics specialists in the same way. That I would call an informatics consult to say, listen, I'm having this quality and process problem within my organization. Is there something that the electronic health record can do to help with this? Sometimes the answer is no. But what the clinical informatics teams bring are firsthand input into the process of workflow design. All of my clinical champions are practicing physicians, and I think having that frontline experience is vital. This is true for the nursing informatics champions as well. They all have a background in clinical decision support and have learned sort of either by doing it or being on the CDS committee some of our general principles of user-centered design. And they bring sort of a measurement and data rigor to it. And so just to reiterate that I think we need to find useful models of collaboration within clinical informatics that mimic what we do on the clinical side. And when things go wrong, they can go pretty wrong. You may or may not struggle with some of the same issues here, but oftentimes some well-meaning group will say, well, we just need to fix this in Epic or your electronic health record. Just give us a pop-up alert and that'll fix the problem. Typically the request is kind of dropped on you, or an IT request. It goes into a giant queue that's never addressed. It's always urgent. People complain that the thing they get out of this process is not, it doesn't actually meet their clinical needs, so the implementation is kind of dodgy in the end. And then it's not really clear what this doctor is supposed to be doing who's got time to work on this project. And the problem is the result is you haven't fixed the problem. the outcome is sometimes sloppy. People are upset, and and it just people learn to resent the electronic health record because it doesn't. All it does is intrude in your work. When it goes right, something very different happens. I think that when we've seen examples of where the informatics person is truly functioning like a medical consultant to this process, and in this case, the ailing patient is actually sort of a bad hospital process or some sort of workflow that's not meeting the desired needs of the organization. And when we take on these projects in the style of a QI project, right, so the same rigor you would apply to a quality improvement effort, iterative cycles of improvement, something really nice happens. And I'll give you some examples. The way to sort of condense all of this into one slide is this visual from Chuck Friedman, formerly from the National Library of Medicine. He called this the fundamental theorem of bioinformatics. And it's basically that the human plus the computer is better than the human alone. And what does not follow from this is that the computer is better than the human, right? Or that the computer can replace the human. None of that is true, right? So what we're meant to do is find opportunities within clinical workflows where that process can be improved by the computer, right? Where maybe it exceeds the cognitive capacity of a human to do it correctly. And one model that seems to have worked is a fairly recent partnership with our Vice President for Quality, Ron Caron, who operates the Office of Clinical Quality Improvement. They have an intake process where they look at pathways and guideline development efforts. Ron was very forward-thinking and realized that he needed to involve informaticists in a different way. And to his credit, was willing to actually support a full-time Epic analyst on his team. So they actually are, they reside within IS, but their salary support comes from quality. And he also pays for the salary of, or part of the salary of two of my electronic health record champions, who are also my medical directors for inpatient and specialty care, Epic. The teams by design are multidisciplinary. There's typically a quality improvement advisor who somebody once referred to them as like a project manager on steroids. They do the sort of project management stuff, but they also do the heavy lift of quality improvement. They have to involve clinical stakeholders, right? It can't be the case that a clinical stakeholder submits a request and then disappears from the process. They have to be part of the engagement. And then I mentioned the clinical informaticist and the EHR analyst. And a couple of examples. Each one of these highlights what I think is a key strength of this collaboration. We had a very motivated PICU fellow named Maya Duwan who wanted to come up with some sort of tool that would facilitate the identification of hotspots. So this was to increase situational awareness about very sick kids in the ICU based on mutually agreed upon status indicators that we could probably abstract from the electronic health record. So, vital signs that were way out of whack, the presence of certain continuous infusions and things like that. And Maya really drove this. She and a nurse, a PICU nurse, together really did all the consensus building, right? They went to all their division meetings. They figured out what that list should include. The informatics person is the person who ended up building it. And this happened in multiple cycles. Each week they would show them a new addition to the checklist. And the feedback I got from my medical director, Eric Shelov, who was on this project, was this was the closest thing he'd ever seen to agile web development on the EHR side. Because it was so, they met weekly, they had a very clear time frame for what they were going to accomplish in how much time. And we don't even know what the results of this are yet, but I highlight it because I think that the model of collaboration for this project was what was very different. This request ordinarily might have languished for 6 to 8 months, but it's because they put together this sort of high-functioning team that it got done much quicker. Another one, I don't know if you guys struggle with this or not, but we're all required to submit these core asthma measures. And we had historically relied on an Epic Classic Smart Form to collect these data in Epic, and it sort of structures how you enter all the data that you need for your asthma care plan. And our rates of completion, successful completion of the asthma care plan, were hovering around 75%, so far below our benchmarked peers. And we kept struggling to figure out why. And they even had a full-time nurse who was going around basically flogging residents every day, saying, if you have any anticipated discharges, make sure you fill out the form correctly. And so this, day to day, but she was only there, 5 days a week. She couldn't work weekends. There was no one there to help with the late discharges. And so we took a step back and said, well, why is it that residents are having so much trouble figuring out this form? Like, what's wrong with it? And what we uncovered was that there are some very profound usability issues with this form. First of all, most of us, when we go to a modern website, expect some kind of feedback if we're doing something wrong. And this form didn't give you any feedback if you did something wrong. So they kept making the same mistakes over and over and over again. No one could figure out why. What we did was one of our clinical informaticists, Levon Utijian, worked with the Asthma Care Committee to drive the consensus. He was sort of in the middle as the project sponsor for IT. And they completely rebuilt the form as a web-based tool that's still embedded within Epic, but now provides the kind of useful guidance and usability framework that people would expect of a modern web form. It includes things like the field validation. And what we saw was when we did this in sort of 2 iterations, we released a first set of enhancements in about January of 2013 and a second set of enhancements in May of 14. You can see that those rates went up significantly. So all of the user level, the resident profiling, we could have done that for years and not made a dent in this. The fact that the form itself was not great for end users. And so to me, the key part that this drives home is that the informaticist plays a role in uncovering the nitty-gritty of why this process is failing at a technical level, perhaps. The third project I wanted to mention is this influenza immunization project. So most of our specialty care providers do not immunize patients primarily, right? That we sort of leave that to the primary care docs, except in some situations where it is the role of the specialist to provide special immunizations for these populations. And the AAP calls out a group of patients that are at especially high risk of decompensation with influenza virus. Kids who have chronic heart disease, chronic lung disease, pre-existing neurologic disorders and seizure disorders and things like that. And so it's true that all kids should get the flu shot. It's especially true for this group. And so because of that, the Department of Pediatrics decided that the specialists themselves had a role to play in making sure these kids got the shot. And when we looked across all the medical disciplines, we realized that this was somewhere between initially 11,000 patients in the cohort. This past year, we expanded it to 15,000 patients. And I'm not going to get into the nitty-gritty of how he did it technically. It's not that sophisticated in terms of, there's a registry that identifies the patients, and then we show some pop-up alerts to the user at the right time in their workflow to say, hey, listen, this is a high-risk patient, a patient who's at high risk for having a bad outcome if they get the flu. Should you give this shot? And we included the ability for them to explain why the patient was opting out, for moral and philosophical reasons, or because they'd already gotten in their PMD's office, and we don't have those records here. And we also gave them a tool to actually monitor division-level performance and provider-level performance, sort of a visual analytics dashboard. What we saw was that the tool itself improved the rates of immunization 20 to 30% above the baseline, which is great. And then in 2015, when we did it again with some other tweaks to the form, it improved another 15 or 20%. There was something really interesting. So I mentioned on the previous slide, or I don't think I said it, but we had this approved as a maintenance of certification project for the American Board of Pediatrics, meaning that if physicians participated in this, they could get credit, professional credit towards MOC for that. Not all the divisions identified somebody who was an MOC champion, but enough of them did that we actually did a sub-analysis to figure out what, was the presence of a local quality improvement champion associated with better rates of improvement. And absolutely it was. That in a statistically significant way, if you had a local champion in your clinic who was really pushing that project, you would on average have a 20% higher rate of immunization. So to me, again, this is, it has to be a team effort. And very specifically, the informaticist cannot be the person who is trying to drive the local change. You have to have somebody who's really going to push for this at the clinic level. So these are the lessons that we learned. Good CDS is meant to augment human capacity, not replace it. Informatics solutions can be designed and should be designed iteratively. You need a clinical stakeholder and a clinical sponsor for almost any initiative you take on. And that small teams tend to be more effective than this sort of anonymous IT request process. Switching gears, I want to talk about pediatric medication safety. Keith and I talked a little bit about this yesterday over dinner. I want to highlight this notion of what we call choice architecture, so representing choice to an end user in a way that invariably will drive them to hopefully the right outcome. And this is all old data from 2001, but the nice thing about pediatric medication errors is that they're pretty predictable and there's a lot of them. So we've got, they tend to fall in these categories of wrong dose, wrong frequency, and wrong route. 80% of them take place at the point of physician order entry, and this is of potential adverse drug events, not actual ones that reach. These are ones that either silently reached the patient and didn't cause harm, or ones that were intercepted by a pharmacist. About 70% of them fall into 3 drug categories: anti-infectives, pain and sedation meds, and then IV fluids and electrolytes. About half of them are IV meds. And it's not hard to understand why this is the case. This is the dosing guidance that we give to our providers for vancomycin. And this isn't even all of it. There's probably another screenshot or two that I couldn't fit on here. There's something like 30 different ways that you're supposed to dose it. And the subtleties in here are, well, what's the per kilo dose, and what's the frequency, and what's the interval, the gap between the different doses. Of course, no one's going to be able to remember this, right? And they shouldn't be expected to. And unfortunately, when it goes wrong, it can go tragically wrong. And so this is an example from Bob Wachter at UCSF, and maybe some of you have read this series of articles that he published. A resident was trying to order 5 milligrams per kilogram of oral Bactrim. And because of their weight, the calculated dose was 193 milligrams right there. And the EHR realized that the closest dose it could give in tablet form was 160 milligrams here. And because there's a 17% difference between those two doses, it suggests to the doctor that they should double check, is this 17% deviation acceptable or not, right? And actually the pharmacist is the person who saw this deviation, called the resident and said, listen, can you just change this to 160 milligrams, just make it a nice round number so that we don't see this alert. And so the resident thoughtfully did that and entered 160 here. Does anyone see the problem? Right, so the units of measure didn't change, and this is 160 milligrams per kilogram of Bactrim. And so they calculated a total dose of 6.2 grams of Bactrim, which is 39 tablets, which, and this is it's a fascinating story. You should read this, either Bob Wachter's book or the 3-part series in medium.com, which I have a link to later on. But he really goes through and explains how this was not just a technology failure. There was all kinds of human process failure steps. There was false reassurances. They had a pharmacy robot that faithfully calculated the dose and dispensed and packaged the 38 tablets. Like, we've done this to ourselves because we haven't thought about how to prevent this error, right? This choice right here. So this is the link, and you guys should take a look at it, especially if you're on the implementation side, because to me this drives home a lot of why we spend so much time and effort trying to safeguard pediatric order entry. And it reminded me of a project that we undertook when I was finishing residency. This was literally my first informatics project ever. I was finishing residency and gotten really involved in the Clinical Decision Support Committee. We were transitioning from a system called TDS 7000 to Sunrise Clinical Manager. And at the time, the CDS committee said that we wanted to look at all of our high-risk medications based on the number of safety net reports that had been submitted to the hospital by staff. And we were going to do something called a failure modes and effects analysis, or FMEA, to understand where people kept messing up these orders and how they were committing these errors. And as an example, this is what we did for ampicillin. We realized that most of the actual errors were administration-related. Most of the potential adverse drug events were interval-related, meaning they were choosing the wrong either Q4 or Q6 or Q12. And so our recommendations were to combine all the dosing forms into an order set, to use the order set layout to guide the choices, and to stratify dose by age group, basically to present this choice architecture in a way that would make sense to a clinician and would obviate the need for them to have to refer to the formulary every single time. And at first, people were a little bit overwhelmed. We took one medication, ampicillin, and blew it up into 30 orders in an order set. And imagine doing this for Tylenol, where there's a jillion different dosing recommendations. So this was it was jarring initially until providers realized the affordance that it gave you, right? We've basically concluded that as long as the provider chooses the correct indication, we can guarantee that because we know the patient's weight, you will get the right dose, the right route, the right interval, right? So those top 3 failure modes in pediatric medication safety, we basically eliminated as long as the provider chooses the correct indication up front. And that's the sort of trade-off, the carrots and sticks. I would never intentionally overcomplicate an order set unless there's huge benefit to doing so. And I mentioned that we tried to do this for all of our high-risk medications. We didn't actually get through the entire list. Sorry, this is another thing, that we could actually, of course, pre-check corollary labs like gentamicin levels when it was appropriate. I think we had the time before the SCM go live to do our top 10 high-risk medications. So for 10 medications, we did this FMEA process and user-centric redesign of the order entry screen. For the next 10 high-risk meds, we could not. We just ran out of time. But it allowed us to do sort of a comparison between the FMEA group and the group for which we did not do the FMEA. And what we saw was, there are probably all kinds of methodological flaws here. For one, the rates of error for the top 3 are much higher than the rates of error for numbers 13, 14, 15, or sorry, 10, 11, 12. But you get the idea that when we paid attention to how providers entered the orders, we were able to dramatically reduce the rates of error, and again, a statistically significant way. We carried these design principles over into Epic. We were very cautious that we did not want to take a step back from a CDS standpoint when we switched from Sunrise Clinical Manager to Epic in 2011. And we spent many, many, many months thinking about what were the different failure modes. Like we're a teaching hospital. At any given time in our emergency department, over half the staff down there are not pediatric residents. They are rotating residents from adult, either family practice or trauma or adult emergency medicine. They have very little familiarity with dosing in a pediatric world. And so this choice architecture theme kind of comes to a head in the ED, or any place where you have lots of relatively naive users. And this is a much older screen. I think the newer versions look modestly better just because Epic has kept up with it. But the things that are highlighted here are, again, we provide instant links to the CHOP formulary. We give you dose accelerator buttons. So for the most common doses, we give you a one-click way to enter them. And this avoids 2 errors. It avoids units of measure errors, right? So it's very easy for somebody to type in 0.035 mg per kg per day instead of per dose. And it avoids decimal point errors. And so, again, the affordance here is if we take the time to put these buttons for the most common doses on your order entry screen, we've kind of killed 2 birds with 1 stone. We are transparent about the calculation. And then we have an absolute max dose. So this is the alert that would have caught the Bactrim overdose, a single dose maximum. As you can imagine, you'd never want to give more than you would for an adult. And so if you tried to give more than the adult recommended dose, you would get this alert. What this doesn't help with is the per kilo maximum, right? It's the way we dose medications in kids is not linear. It's linear up to a point when they're younger, if you're dosing by kilogram, but then when they hit something like 50 kilograms, it plateaus. And so we had to have the absolute max for the adult weight, but we also had to have the weight-based max for kids that were still on the linear part of it. And that's what this is showing, that in this case, this was actually from an RCA as well. An adult rotating resident tried to order 0.1 per kilo of Versed for a heavy child in the emergency department. And the calculated dose of 0.1 per kilo would have been enough to, sedate a horse. And so we almost, this was actually intercepted, but we almost really, really hurt this child. And so we realized that we need to have not just the weight-based max, but also the absolute max for all these medications. And it's complicated to build. I mean, it's time-consuming. I won't say it's complicated, but it is time-consuming. This was the sort of the Epic version of that choice architecture, where as long as the user chose the correct indication, we could guarantee the right dose, units of measure, interval, frequency, et cetera. And I would say that you can actually accomplish this much more elegantly with Epic's newest tool set, using order panels. You can even suppress the ones that are not relevant. If the kid's clearly not a neonate, you can suppress the ones that are related to just neonates. So you can actually slim this list down a lot today. We would do things like, if it was a nephrotoxic medication, we'd make sure to include the most recent creatinine value. So relevant lab results at the point of order entry, right when you need it to make that decision. And then other affordances. So for IV fluids, we couldn't directly suggest a rate, but there is a way that you can sort of do a calculation and show it to the users. So, we do the Halliday-Seeger method, the 421 IV fluid rate calculation. I think you guys do body surface area here, or you did when I was a med student. But in any case, you could come up with a way to include that. Charlie's nodding because I think in oncology they always use body surface area. And so you can show that here for the user if you want. So there's lots of things you can do to make the life of the prescriber easier. And then we had this one interesting question. Someone said, well, so, the Metaspan dictionary that we use for our medications, there are tens of thousands of things in this thing, and we couldn't possibly create alerts for all of them. We did it for everything that was on the inpatient formulary and very frequently or commonly ordered, but not for all the meds. So someone asked the question, well, how is someone supposed to know if this med has max dose alerts or not? So we had to come up with, I don't even know, I'm a little bit embarrassed because we don't have a good way to show that this is working. But it may not be the best way to protect the end user, but it's at least something to say that, by the way, you're not going to see a max dose alert if you try to do something crazy with this medication. So these were the summary of that section is that, we want to represent choice in a useful way. We want to limit choice to the most appropriate options. We want to provide helpful guidance for complex decisions. And the best way to get this is to look at your med safety data to figure out where your errors are being committed and what's the best way to safeguard them. And you'll probably find some really interesting patterns. And to do this iteratively, we have a nice feedback loop between our med safety group and the CDS committee where they periodically look at all the safety net reports. A year or two ago, they realized that there was this modest but significant rate of errors related to vancomycin, and we actually pinpointed down to a usability thing in the order set itself. And then the answer is not always obvious. And I say that because, again, everyone loves to jump to the idea of a pop-up alert or some sort of notification. I'll give you the example of, in our emergency department, our ED champion, Joe Zork, wanted to dissuade users from ordering chest x-rays routinely on kids with bronchiolitis. It's kind of a useless test in that population. It's excessive radiation, and it drives up the cost of care for no reason. And so they tried as much as they could to actually sort of, we don't know why they're ordering it. It's not even in the bronchiolitis order set. So omitting this chest x-ray order from the bronchiolitis order set was not sufficient to dissuade users from ordering it. You could say, well, anytime they order a chest x-ray and the diagnosis is bronchiolitis, let's show them a pop-up alert. But people would go crazy with that. And so what Joe did, which I thought was kind of elegant, was he included the chest x-ray order in the bronchiolitis order set, but it was clearly labeled not for routine use in bronchiolitics. So he called it a do not order set, right? So, because you want to give the user who really needs to order the chest x-ray an easy way to do it, but you can use that moment, that one line of text to actually instruct them that, by the way, don't click this unless you really mean to do it, right? Unless you have some compelling reason to do it. And the inclusion of the do not order set was enough to start to turn the dial on these chest x-rays. So you can get kind of creative if you just ask your end users where and when they need that information. And I'll conclude with this last section on the design of alerts. This is a topic for me because, again, every other request for decision support, people equate decision support to mean alerts. And I think that even if you're going to do an alert, you can do it thoughtfully. So any guesses what this graph represents? It shows a bunch of data points over about 15 years of time and no clear trend. A friend of mine, Tom Payne, who is currently the president of AMIA, dug up every mention of drug-drug interaction override rates in the medical literature over the past 15 years and plotted them. And he says that despite all of our hand-waving about alert fatigue, we've literally done nothing to improve the rate of overrides in all the published literature. So it's exactly the same 15 years ago as it is today. And that's kind of an embarrassment to the field, right? The fact that we have not figured out a way to encourage users to pay attention to alerts, and I think it's because we're not showing them the right alerts, and we're using these alerts inappropriately. We're showing low utility alerts to users, and we're expecting them to make, to maintain this vigilance for something that pops up all the time. At our last calculation, we were showing 0.6. Well, we've made improvements since then, but when we initially turned on drug-drug interaction alert checking in Epic, we were showing 0.6 alerts for every order that was placed. So a little bit more than half the time you placed an order, you would get some kind of weird interaction alert. And we had the exact same 93% override rate as every other institution. And it's not just drug-drug interaction alerts. This was a category of alerts called alternate therapy alerts. This is when Epic is being clever and tries to check with your payer to see if this medication is covered by your formulary. We saw that we were having about 60,000 of these alerts fire per year. And nominally, these are supposed to be helpful, right? It's telling you, hey, you know what, this med's not covered by the payer. Can you choose something else that's more appropriate? And I did a breakdown in this sort of cascade-style diagram, but the key point is that only about 10% of them were actually found their way. In only 10% of the cases did the user actually choose the recommended alternative and submit it. So again, we're doing something tragically wrong with these med alert checking and pop-up alerts in general. So thinking about ways that we can improve this, I wanted to highlight one specific example. We had a particularly bad quarter a few years ago where 2 patients with urea cycle defect in our NICU had delayed diagnosis of the disease. And our metabolism docs really have tried to impress upon us the importance of early detection and early treatment for these kids so that they can improve their chance of a good long-term outcome. And the problem is that the initial symptoms are very nonspecific. Kids come in with respiratory distress. They typically end up on a ventilator in the NICU. And it's always in this newborn period in the first couple of days of life. So their initial suggestion to us was that, listen, every time you order an arterial blood gas on a preemie or a patient in the NICU, let's show an alert to the NICU doc that says they should consider sending an ammonia level to check for this. And at face value, it sounds like it's not such a bad idea. You want to teach the NICU docs that respiratory distress and specifically respiratory alkalosis should suggest to them the diagnosis of urea cycle defect. But this has some, and it wouldn't be hard to code that. And we know which baby's in the NICU. We know when you order an ABG. This would be an easy alert to program, but it's not the right alert to program. And I'll try to explain why. There are a few problems. When you look at how often ABGs are ordered in the NICU, it's in kids less than 2 weeks of age, something like 1,600 times a year. And we see about 2 to 3 cases of urea cycle defect per year. So that means that the other 1,597 times of the year, this alert would not be helpful to the end user. And you can demonstrate this using all the stuff we learned in biostats, do a little 2x2 table. This has, it's a very sensitive indicator. Yes, you will absolutely catch patients with this disease if you send an ammonia level on every baby that has an ABG, but it's not a very precise indicator. It doesn't have a high positive predictive value. In fact, the positive predictive value of this alert, as suggested by the metabolism docs, would be about 0.19%. And so I'll ask you this question, because people scratch their heads like, why don't the docs just pay attention to these alerts? If 99 out of 100 phone calls you received were telemarketers, you would eventually stop answering the phone, right? And that's exactly what alert fatigue is we show low utility alerts to providers all the time, and we expect them to do something thoughtful with it. So I think that false positives are enemy number 1 for CDS implementers, right? This is our role, is to try to reduce the rates of false positives. And we can do this, right? Hyperammonemia doesn't present in the first day of life. So get rid of the 0 to 1 day age group. If you have not diagnosed it by 7 days, the gig is up, right? You've missed the opportunity to really change the outcome for this patient. So stop showing it at 7 days of life. There's no reason to alert the provider every single time an ABG is ordered. Once they've concluded they don't think this patient has a urea cycle defect, stop bugging them. And if they're not sure, give them a way to remind them later. So we implemented all these things. And in the first 6 months that the alert was live, it fired 184 times, so not horrible. It resulted in 63 ammonia orders being placed. So a third of the time, the clinician found utility in this alert. And that's much higher than the 10% of the time that they find the same utility for drug-drug interactions and other things. It actually resulted in 1 case being diagnosed because of this strategy. So if you figure out the positive predictive value of the alert, it's something like 0.5%, meaning 0.5% of the time when the alert fires, the patient has a disease. But in the alert itself, it actually says, by the way, the hallmark of this is a respiratory alkalosis. So if you see that specific pattern on their ABG, you should really consider this disease. And that, so in the case where they actually ordered the ammonia, the positive predictive value was 1.6%, which I actually think is not that bad for an extraordinarily rare disease. So you've gone from a population with an incidence of 1 in 30,000 live births to 1 in 63 ammonia levels sent to diagnose 1 case of this. So the whole point of this is that we have to be extraordinarily thoughtful about these pop-up alerts. And the easiest target is to figure out how to reduce the false positive rate. All of you have probably heard of these 5 rights of clinical decision support. Jerry Osheroff and Jonathan Teich and others have published this. HIMSS actually has this CDS Implementer's Guidebook that's worth reading. And the 5 rights are sort of making sure it's the right information, that it's evidence-based, exactly the information you need to make the decision, that it's the right person. So it may not be the case that you have to show this alert to the physician. Maybe there's a form of decision support you show to schedulers or to nurses or to whoever. The right format. Not all CDS has to be interruptive. The right channel, meaning maybe it's not even the electronic health record that's the target here. Maybe it's the personal health record of the patient. Or maybe it's a piece of paper that you hang on the bedside that's generated from a report in the EHR. Lots of options for decision support. And then at the right time when the information has the highest utility. So over the summer, my medical director and associate CMIO, Eric Sheloff, sent me this picture. This was his wife was trying to remind him that the next time he left the house, he needed to go buy toilet paper. And he wrote to me, he said, I think Emily's trying to tell me something. And then he wrote back, he's like, Bimal, this is the most perfect form of decision support I can think of. And he's not wrong. We decided that this was actually the right information. Hey, we're out of toilet paper. Eric, go do something. Go buy some toilet paper, please. It's the right person, so any user of the bathroom who can buy toilet paper. It's the right format. Everyone immediately understands what that empty toilet tube represents. It's in the right channel, so it's embedded in the toilet goer's workflow. And most importantly, it's at the right time. She was smart enough to put it on the lid of the toilet so that you could not commit the error of learning this after the fact. And again, credit to Eric for that. So to try to tie this all together, I think that there is a utility function for decision support. And if people are interested in sort of thinking about this and writing this up, we've got to sort of think differently about decision support. And I think that the utility of an alert is a function of both the benefit that it confers to that provider, to that patient, and the actionability. Right? And what I mean by actionability, what I mean by benefit is the degree to which you can avoid harm by intervening at that moment. And so you can estimate that using failure modes and effects analysis or other sorts of standardized risk assessment tools. Actionability, in my mind, is the degree to which you can satisfy those 5 rights. Right? You might have a great opportunity for a great idea for decision support, but if there's no clean way to implement it in the electronic health record, it fails the actionability test. And then I think that the interruptiveness of your decision support can be is proportional to that usability, the utility function, right? So if I'm certain that this is important information, and if I know that there's a clean way to deliver it in the electronic health record, by all means use a pop-up alert. But if I can't, then maybe I should think of something else. So this is my sort of pseudo-math. Interruptiveness is proportional to utility, which is approximated by benefit times actionability. And in this framework, you can sort of go through the 3 examples here and decide mentally if you think this is worthy of a pop-up alert, if there's some other way to do this. So the first one, I want to prompt users to give pneumococcal vaccine to patients with sickle cell disease, especially if they're delayed in receiving it. By all means, pop-up alert, go nuts, right? The system knows which patients have sickle cell disease. The system knows which patients have and have not received the vaccine. The system knows that the user who's seeing them in hematology clinic is the right person. This meets all those hallmarks of actionability and benefit and all that stuff. So show them that reminder in that workflow. The next one, prompt users to consider renal dosing for nephrotoxic medications. And this one, I think, falls apart if you think about the potential benefit. This is of benefit to users who are at risk of developing nephrotoxicity. But to the general user, it might not be that, patients that are at risk of developing nephrotoxicity, but to the general population of patients, it may not be that helpful. So if you can figure out a way to make this very precise, to target patients who already have pre-existing renal failure, then again, consider showing them alert in this situation. And the last one, remind users of idiopathic reactions to certain medications. So you can see this as sort of a knee-jerk response, right? You know, your med safety group realizes that you saw a couple of cases of Stevens-Johnson syndrome after Bactrim, and they ask kindly for an alert to warn providers that Stevens-Johnson is a known but rare side effect of Bactrim. And this, to me, doesn't work in any regard, right? Like, unless you're telling them to avoid Bactrim altogether, which you're not, unless you have a way to predict which kids are going to get Stevens-Johnson, which you don't, unless they've had it before. Like, this is not a useful target for decision support, in my mind. So this is the whole principle. So we're trying to avoid treating everything like a nail when it's not. And there's a lot more, we have a lot of different hammers in our toolkit. And so good CDS ultimately does avoid this. And that's the end of the talk. I do have one extra, this is sort of additional reading for people who want. There's a lot of new literature on how to design alerts to optimize their usability and their sort of visual appeal and things like that. So I point you to these papers by Horsky and Zhang for anyone who's interested. And I'll take some questions.
Bimal, have you looked at evaluating the ABG result and only at, and so if it's not a respiratory alkalosis, then the question is, could you just look at the ABG result and then if it's not a respiratory alkalosis,
Right.
then let it slide?
So, and that's a very good point. So are there ways that we can refine this even more? And I'll defer to Mike, who's a neonatologist. Would that be of use to the group? And we could certainly look at those components and try to figure it out.
I mean, sure, I think there's a potential for being more sensitive. The overall number is pretty low, but one of the most valuable things we found from it is even just having that alert there is a teaching point for folks, so that they'll encounter this environment, they'll encounter this bit of information there in this specific circumstance, but then they may be in an outside hospital and they'll see, hey, I've got this kid who's breathing, who's tachypnic, doesn't look like he's working that hard, but he has respiratory alkalosis, and just that association, because if you only observe that when you see a case, it's not going to be enough to teach a whole set of trainees. So even
Right.
just bringing it to their attention as a teaching point is valuable.
But that's a good point, is that again, if you wanted to reduce the false positives even more, there are probably things we can do with the lab result itself.
Room for one more question, maybe, before we get to break.
I'm just curious. I see these solutions that are local solutions. How do they ever get generalized?
You mean across hospitals? Mm-hmm. Yeah, that's a very good question. And it's sort of I think the next kind of grand challenge for CDS implementers is how do we get out of this model where every single hospital has to do it on their own. I mean, we had to locally derive those dosing rules, right, the max dose rules, because the stuff that Epic provided out of the box wasn't all that useful for us. There is a lot of push towards shareable decision support. So imagine that the CDC is the expert in travel medicine and which alerts you should provide to people when they're going to travel to Botswana, they've recently been to Haiti or whatever. Why doesn't the CDC publish a web-based API that we can consume and inject into the electronic health record? The models for that sort of shared decision support, where you've got the experts maintaining the repository of information, and somebody puts a nice little wrapper around it so you can have sort of a useful web-based application for decision support, and then the electronic health record would actually just represent that tool. They're evolving. You may have heard of this standard called SMART on FHIR. So SMART is substitutable medical applications and reusable technologies out of Boston Children's Hospital. And FHIR is an evolving standard for representing clinical facts over JavaScript object notation, or JSON. And it basically adds, it gives the ability for web developers, not necessarily medical content experts, to design robust clinical decision support applications. And Cerner and Epic and all these organizations, all these EHR vendors are slowly coming around to this idea of maybe we should be able to host these, or not host, but display these SMART on FHIR applications in the electronic health record. The way it would work is that if I subscribe to that application, the CDC Travelers Alert app or the AAP immunization app, I send a sparse set of data from my electronic health record to that knowledge vendor. They compute over a set of rules and they return a recommendation, or they show a nice pretty graph or something. So that's I think it'll probably happen in our professional careers. I hope it'll happen, because there's no point in every single children's hospital in the country and every single adult hospital that cares for kids to separately engineer all these solutions. But that's unfortunately the state of the state right now.